Assalamu alaikum wa rahmatullah. Our topic today is incompatibilities in parenteral preparations. We'll be covering these learning outcomes. First, we give you the categories of incompatibility in parenteral preparations. We will also expose you to sources in literature you need to uh, use, or you need to know. These sources are helpful to find out information about possible potential incompatibility in the practice setting. Also, we are going to expose you to summary of areas of concerns regarding the compatibility or incompatibility when two medication are given in the same IV set, mixing in clinical practice IV set or in the same syringe or in the same container. These are different types of practice. We will give you possible interaction that you should be aware of in all these different settings. First, incompatibility is undesirable reaction that occurs when two or more drugs undergo either a drug with another solution, or a drug with a container, or a drug with another drug. So these mixing, when you mix two products together, or sometimes even you use certain type of materials either in the IV set or as a container, sometimes also undesirable effects occur. Mixing parenteral in general is not recommended, but there are situations, many situations that requires this mixing. So it's a common practice occurring. It is not generally recommended, but in practice you will find situations mixing is necessary and helps in overcoming. So that's why we need to understand when we can mix, when we cannot mix, and what are the potential. How can we identify the risk of mixing by this knowledge? By the end of the lecture, you should be aware of the main sources that you predict this hazard, even if you don't have information, but you be suspicious that possibly there will be a undesirable reaction occurs, and this will lead to serious problems. So it's very serious issue. Okay. Sometimes why we mix, and I told you examples of the situation we might need to mix. For example, if venous access is not available, limited in a patient with difficulty to establish a venous access, so you cannot establish more than one venous access easily. So in this case, you will think of using this access to give the patient all his medications. So this one situation, you find that they difficult situations, they were able to establish a venous access. Sometimes they need to do a minor surgical to expose the vein so that they can establish a line. So the possibility of establishing more than one line will be more hazards. Okay, multiple drug requiring parenteral administration in short period. For example, a home care visit, or the physician, he has to finish because he has a schedule for many visits to fulfill. So he will not be able to stay to finish one line, one infusion, and then start the next one, or establish more than one line. So they tend to mix the medications in order to shorten the time. So this is one occasion. Using, for example, a syringe driver for palliative care also at home. But practically you cannot establish these two syringe drivers for the patient, and it will be always also something uncompliance for the patient. Palliative therapy, for example, is used for end-stage cancer patient to relieve the pain or all the symptoms associated with this situation. So commonly to mix these medications and will be given using with a syringe drivers, possibly at home sometimes. Okay, hazard of parenteral admixture is very serious, and that's why there are many serious occasions that occur. That's why it's a safety issue, patient safety issue, so should be considered highly. And we have many reports in the literature about even this patient death due to incompatibility or during admixture. For example, there are number of occasions FDA safety alert reported for mixing calcium and phosphate in TBN. Calcium and phosphate are main component of TBN, but they are prone to interact together, and this interaction results in insoluble salt of calcium phosphate. This insoluble salt, if occurred inside the IV set, so the problem will be serious, and this led, as you see, to even 2 deaths for patients. So very careful to mix this, and we will give you some precautions in TBN preparation to avoid this hazard. Also, medication errors in parenteral administration is much more serious. You know, parenteral is an emergency. You give the drug directly into the bloodstream, and then this will be very can lead to very quick and rapid onset, because intravenous is known with the rapid onset. It's emergency treatment. Also, the complication will be very rapid, so this issue needs more care. For example, if medication errors, normally that you replace a medication for a patient with the wrong one by mistake, human error. So, for example, substitution of potassium chloride for heparin in 3 premature led to serious issues. And the infant should take heparin, you give him potassium chloride. This can lead to serious life-threatening issues. Contamination of a parenteral solution during open heart surgery, for example, glutamate aspartate solution during open heart surgery, can enhance myocardial preservation. Okay, it can be very serious, because they give glutamate aspartate to enhance myocardial preservation during surgery. So contamination of this will expose the patient to serious infection that might be life-threatening for that patient. Also, there are a number of issues, general issues, that you should always be aware of. For example, there are a wrong conception in the clinical practice that these large volume fluids that are given like saline or low concentration carbohydrate, dextrose 5%, can be used as vehicles for any drug, can be used as vehicle for parenteral. So dilution with these is expected to cause no hazard changes to your parenteral, but this is not the case. These are not water, sterile water for injection. These are fluids that are necessary for certain situation given to the patient. So they were not formulated to be vehicles for other drugs. Remember that. And we'll see that these, some of them has different pH, like dextrose 5%, slightly acidic, so this can be serious for a number of drugs. So you should be aware of this and inform the health team with these issues. Also, small volume parenterals ampoules, small volume less than 100 ml, probably smaller. The most common is less than 10 ml, 5 ml, majority. They were not stable. They might not be stable when diluted with large volume fluids. So it's not guaranteed that when you dilute a 1 ml ampoule in 100 ml or 1 liter of saline that it will remain, it will just diluted and nothing will change in this drug. This is not always right. Compatibility when you mix two small volumes together will be higher even than the mixing of a small volume with a large volume. Why? Because these small volume usually are highly concentrated. The drug, the dose is included in 2 ml, 3 ml, 5 ml only. And when you mix two ampoules together, two small volume, 2 5 ml, both drugs are in high concentration. So the reaction will be more prone to occur. Also, the change in pH when you mix 5 ml with 5 ml is high. If you are mixing alkaline with acidic, the change of both pHs will occur, and this will lead to a more serious chance of interaction. So generally, the most the high potential for incompatibility will be when you mix two small volumes together in one ampoule. So this is should be avoided to in clinical practice. Also, the absence of any visible change, color change, gas evolution, precipitation, doesn't guarantee that there is no incompatibility. Most likely it is, but you should investigate also that the drug did not change it or degrade it to a degradation product that might be soluble and does not cause any change, but the activity has been lost. This is sometimes occur. So there are examples of this that has been discovered by investigation. Okay, important issues also related to incompatibilities is the sources of incompatibilities, main sources. This is very important. Because if you are familiar with this, you can predict the potential for incompatibility. The incompatibility can occur by just defect occurs to the active therapeutic agent, the active drug. The active drug hydrolyzed, changed, precipitated, degraded. This is possible. Also can occur to the additives. not necessarily the interaction will lead to problem in the drug only. For example, preservative, stabilizer, solubilizer, these, if they precipitated in the when admixture, also incompatibility occurs. So not necessarily that the drug will not interact or will not precipitate, that this you have to look also for the chances of interaction with the excipients added in your formulation. Change in pH upon adding an agent is very important, because the pH will lead to variation in ionization in the and ionized to unionized ratios, and this will change the properties, either the physical or the chemical properties of the solution. So you might you have to look or monitor what is the pH of this one and the pH of the other one. If they are highly different, this will be a source of incompatibility. Also, the concentration of additives is an important issue. If you are using very high percentage of a solubilizer, for example, or high percentage of a surfactant, high percentage of stabilizer, this should be considered that might cause or might be a source of incompatibility too. The time of contact of ingredient, you're mixing them, the longer the time, that the higher the chance of incompatibility. Okay, so you minimize always the time of mixing, the time of interaction. If you are going to mix, you should mix it with the shortest time to avoid the possibility of interaction. Also, acid-base reaction, very important. Acid-base reaction is common chemical reaction, occurs and changes the activity of your drug. But if you have two drugs, one of them is acidic, the other one is alkaline drug, you can identify this easily from the chemical entity. When you see sodium barbiturate, this means the drug is acidic or alkaline. Ask yourself. Sodium barbiturate is formed with when you react barbituric acid with sodium hydroxide to produce a soluble salt. So your drug is acidic. Barbiturate should be acidic. If it is present in a sodium salt, this means the drug is acidic. On the other hand, if it is presented in hydrochloride salt or sulfate salt, this means it is alkaline. Okay, so the possibility, if you have two, one acidic, one alkaline, or one basic, so the chance is high for incompatibility. Also the temperature. The temperature is because temperature always catalyzes reactions. So temperatures should be minimized to, or the impact of temperature should be minimized. So for example, increasing the degradation rate of antibiotic is common to occur in high temperature. So when you increase the temperature, the chances of antibiotic and most drugs. So you might always, if you are going to store this for short period, it should be stored in refrigerator because some other antibiotics like ampicillin decomposes upon freezing. So freezing harsh, minimizing the temperature to a certain extent below zero might be a problem for some drugs and also cause degradation. So common practice in IV admixture is storage should be in refrigerator, not in the freezer, not in room temperature, to minimize the chance of interaction. This is very common. Okay, the order of mixing is important. The order of mixing and how the procedure of mixing, and we will see this very serious in TBN preparations. So if you follow the guidelines how to mix so that you minimize the chance of incompatibility. This is important issue. So uh, the container, the material of the container sometimes can cause interactions with some drugs. We'll see the insulin with glass and plastic. The insulin absorbed on the walls, so this is a problem. Warfarin, methotrexate. There is a methotrexate with plastic is common. The materials of the container sometimes should be no, this is mesohexatal. It's correct. Okay. So cationic anionic interaction is also an issue. Acid base, cationic anionic, both are a problem. Okay, and they are interrelated sometimes. So heparin sodium or any sodium salt of a drug with an acidic or tebromycin sulfate salt, this means heparin is here anionic and tobramycin is cationic, so the chance of formation of heparin tobramycin is there. Okay, interaction between them and causing a new compound as a result that will deactivate both drugs. Okay, you should pay attention to these sources and be aware of this to predict the potential of incompatibility. Also, the categories of incompatibility in general can be divided to three main categories: physical, chemical, therapeutic, okay, or pharmacological. Physical incompatibility and chemical incompatibility are overlapped together, but we can differentiate between them by one issue. I consider the interaction is physical if I can see real change, that noticeable change occurs upon mixing, and this is more common in admixture. So this gives you alarm that there is incompatibility already. Like changing color, if you mix two colorless solution and you end up with a milky or yellow or blue, this means there is interaction resulted in a new compound, and this new compound has different color. So this is obvious. Or you mix together and you saw turbidity. Turbidity means there is something precipitated, either the drug precipitated because of its solubility, or a new compound formulated, a new salt formulated that is insoluble. Or you see evolution of gas. Evolution of gas means chemical reaction occurred, and as a result of this chemical reaction, a gas is evolved. So you don't know what happened. There are something changed. If you don't see this and you investigated this interaction and you found by analysis that there is a new compound, we call this that occurred while no signs appeared is considered a chemical incompatibility. Okay, but the physical incompatibility gives the sign, doesn't mean that no chemical reaction occurred. No, we consider it physical incompatibility when we see a sign, but possibly the reason for this physical or for this sign is a chemical reaction. This is the main difference. Majority of incompatibility appears with signs, noticeable signs. Okay. Examples of physical incompatibility is precipitation upon dilution. Yeah, we see turbidity, which is turbidity appeared when you mix two drugs together. So especially for drugs with very poor aqueous solubility, this is seen when they are formulated in non-aqueous solvent. So when you mix them or you dilute them with other parenteral, you might see turbidity. So this is due to precipitation or change in the solubility. Examples of drugs with poor solubility formulated in uh, non-aqueous solvent or co-solvents used: diazepam, digoxin, clonazepam. These are phenytoin. These are commonly our common examples for poorly soluble drugs. I will give you examples. So you need only to remember diazepam as a case. We will for this class of uh, incompatibility. Diazepam is very poorly water soluble, and it is formulated in a formula containing 50% propylene glycol and 10% ethanol. So they found upon dilution of diazepam, if it is diluted, that slight turbidity occurs upon dilution, but this turbidity disappeared, uh, clears upon mixing when you just shake. But if you continue to dilute beyond four folds of the volume of diazepam, you will see an opaque white precipitate. So it clears and then it pertain again to certain volume. If you continue to dilute, it will disappear. So you have to be aware of the recommendations of this dilution in order to avoid a serious problem. If you know that diazepam can be diluted to up to this volume, or if you are diluting higher, you should not, this volume between this volume and this volume, the possibility of precipitation is higher than this one. So this is a typical example of precipitation occurs due to poor solubility of the drug. Precipitation of drug due to pH change upon mixing is also a common. pH, as we mentioned, or control the ratio of ionized, and of course the ionized is the more soluble form of your drug. If you change the pH to that reduces the ionized, this means you are reducing the solubility of the drug and you might see a precipitation. For example, poorly soluble weak acids like verapamil, amiodarone are used with an HCl salt to solubilize them. If you change this acidic pH by mixing with alkaline drug high pH, the possibility of precipitation is high. Okay, so on the other hand, poorly soluble weak acids will exhibit the same issue because they are soluble in alkaline pH. If you mix them with acidic pH, they might precipitate. But this is very important. We choose phenytoin to be an example for this. Phenytoin is a poorly soluble acidic drug. Is formulated in pH 12, and dilution of phenytoin injection in infusion bag can be very serious. It is recommended to avoid this because pH 12 is extremely high, and you will not find, it's not common to have similar pH. For example, dextrose 5% or glucose 5%, pH is slightly acidic. If you are mixing this, or even neutral 7 saline or other solutions, so this is very serious, can lead to immediate precipitation of phenytoin, and this can lead to serious problems in IV administration, embolism, and so on. So it is recommended not to mix phenytoin, with other uh, parenteral formulation. Okay, very serious issues has been reported due to precipitation. This is, for example, the generally we don't recommend to mix monovalent cation with divalent cation, because divalent, they might change the salt to the divalent. The divalent cation, like calcium and magnesium, usually their salts are poorly soluble, so they will precipitate. If you mix a monovalent cation solution of a drug with uh, another divalent containing parenteral solutions, this might form the insoluble directly form of this salt and resulted in precipitation. So, for example, mixing magnesium sulfate 50% and calcium chloride 10% result in precipitation of insoluble calcium sulfate. Calcium sulfate is insoluble. Those, even both of them are divalent cation, however, the solubility is different. So the chance of calcium sulfate formation is high upon mixing of these two. Mixing of calcium with phosphate, carbonate, bicarbonate, tartarate, sulfate is should be avoided in order to avoid the formation of the insoluble calcium phosphate, calcium carbonate, calcium bicarbonate, and so on. So this has been appeared as warning, because warning that mixing calcium containing solution uh, like Hartmann's solution is a TBN solution containing calcium, a calcium containing solution, parenteral solution. They found that mixing Hartmann's with ceftriaxone, patient taking ceftriaxone and they injected this or diluted in Hartmann's while he's taking this nutritional, they warned that precipitation of calcium ceftriaxone occurred and this caused a serious problem. So this is very serious issue, the issue of salt, insoluble salt or ionic reaction forming a soluble substance. And we mentioned the effect of solubility if the drug is poorly soluble and formulated with non-aqueous solvent with high concentration. Give diazepam as example. We mentioned also the pH effect. For example, phenytoin is prepared in parenteral solution with pH 12. When you mix it with lower acidic or different pH, it might cause precipitation. The third thing is ionic reaction. For the ionic reaction is the third example. So we highlighted this in red because it's safety tip or safety issue belongs to this domain. So very important, very serious. Also another example of physical incompatibility is the ionic reaction forming insoluble substance, and this is really very serious, as I mentioned, especially the calcium and phosphate issue in TBN. Okay, chemical incompatibilities, as I mentioned, is incompatibilities resulting from chemical interaction. Chemical interaction can occur by degradation. Your drug degraded by hydrolysis oxidation. This is a chemical interaction, or even by formation of a new entity. The drug reacted and resulted in a new compound that is different than the active drug. As I told you, chemical incompatibility is classification of chemical and physical here looks for incompatibility is looking as the main difference is if this interaction did not appear with a noticeable sign like color change, evolution of gas, or precipitation, you can assume the possibility, not necessarily there is no interaction. There might occur a chemical interaction that resulted in no signs. So you should also investigate more to make sure that this mixing did not cause interaction. So the majority of chemical incompatibility occurs by hydrolysis, oxidation, reduction, complexation, and in order to make sure that this is a chemical and not physical, you need to analyze. So without analytical tool, nobody will discover. And usually this occurs when they see some clinical outcomes, weird clinical outcomes, either toxicity or change in the therapeutic activity. So they dig in and investigate by analyzing what happened to the drug after mixing. And this requires another tools to give you evidence of this formation, analytical technique, HPLC, and so on. We'll just give you important chemical incompatibilities that occurs in the practice. For example, direct interaction of tetracycline with calcium is very common, and even we in oral, not only in parenteral, we you know the example of drug food interaction of tetracycline with dairy products containing calcium, that they form a calcium tetracycline complex, which is insoluble complex, so they prevent the absorption of calcium. So that's why we always recommend to take tetracycline empty stomach and avoid taking dairy product within 2 hours of administration of tetracycline. Polymerization is another chemical issue that might cause serious problems. Cephalorodine tends to polymerize at acidic pH. So changing the pH made the drug to form a polymer of cephalorodine. So polymer can be a dimer or trimer or higher. 2 or more molecules start to form a complex with each other. Sometimes this, or in case of cephalorodine, they found that this caused hypersensitivity reaction, anaphylactic shock for some patient. When they investigated, normally if the pH is not acidic, this doesn't occur. They investigated that the reason for that is polymerization of cephalorodine in acidic pH. So mixing with that changes the pH to acidic can lead to this problem. Okay. Cationic anionic interaction. We mentioned this earlier in the physical, in general, in the sources of interaction. For example, if you mix cationic drugs, for example, aminoglycosides are usually cationic drugs that are formulated in a sulfate salts, amikacin or gentamicin, kanamycin are commonly. They are incompatible with heparin. Heparin is an ionic drug formulated in a sodium salt, heparin sodium salt. So the possibility of cationic anionic will result in deactivation of both drugs. So deactivation of both drugs will occur. Conjugation is another type of chemical incompatibility. Conjugation of penicillin with other proteins during infusion. If given with a protein drug during in infusion fluids, they found that penicillin conjugate with the protein, and this will deactivate both drugs too. pH change. pH change is very common to cause problems. Epinephrine loses 60% of its activity when added to alkaline solution like sodium bicarb. Okay, insulin also are known to denaturate when exposed to pH, alkaline pH. Alkaline pH causes denaturation. Denaturation of protein means deactivation, means degradation of the protein, or forming, changing the active structure of the protein. So very important to avoid the alkaline pH in case of insulin mixing with any other drug. Therapeutic incompatibility is categorized as incompatibility, but actually here we're not concerned with this. This can result by common drug-drug interaction issues that has to deal with antagonism, synergism, drugs activity change due to co-administration with other drug. It is not due to mixing or giving them. It will happen even if they are given with different routes of administration. So it is not, we just mentioned them that they are considered incompatibility in general, but they can be discussed under drug-drug interaction more. Examples for this are numerous, and you are aware of this in other courses like pharmacology or therapeutic courses. This is very common. For example, metabolic incompatibility or metabolic drug-drug interaction is common, that enzyme inhibitors can lead to changing the bioavailability of other drugs and shows toxicity when co-administered with other, like cimetidine, known enzyme inhibitor to cytochrome B. Any drugs that metabolized with this enzyme will be preferentially, the metabolism will be reduced, and this can lead to serious adverse effects and needs dose adjustment or avoid the co-administration together. Admixing drugs in the same syringe. These are the different categories of practice. We will just give you examples of incompatibility that occurs due to these practice. Admixing drugs in the same syringe means mixing them before injection directly, syringe. We're not talking about the IV. This is a small volume mixing. The small volume mixing of drugs is also sometimes needed. We mentioned the chance of incompatibility is high, so but in certain situation it is required. For example, preoperative medication that is given to a patient before surgical operation, shortly before surgical operation, is a combination that should be given quickly, and normally they might be mixed in one syringe. For example, analgesics like hydromorphone, atropine, anticholinergic drugs, antiemetics, promethazine, these are known as preoperative medication. Palliative therapy, we mentioned them before. Palliative therapy for pain control, especially in the stage cancer patients, are given to improve the quality of life of these patients and reduce the pain or any suffer they might feel. So these are known to be combination of narcotic, analgesic, sedatives, and the antiemetic drugs, morphine, hydromorphine. These are commonly needed to be mixed. So we will just give you recommendation to avoid any incompatibilities of this. Palliative care, usually this is a syringe drive that will be in this small volume, can be 50, 100, 50 ml maximum, 20, 30 syringe, and this is a syringe drive that will be adjusted to certain speed. And sometimes this palliative care is given subcutaneously, it's not necessarily intravenous. Small volume is pumped to the patient constantly to give him necessary medication. So it's a small few, when slowly given subcutaneously, sometimes intravenous. It depends on the need to control the case, the symptoms of the situation in palliative care. These are common combination of drugs used in palliative care, available as combinations. Haloperidol with midazolam, hydromorphine with clonidine. They are already mixed, available as a combination that has been investigated. This is helpful to be used directly, but sometimes you need more drugs to be mixed with this. So these combinations of the three categories, how do you know what is your reaction in order to recommend this decision of mixing them and formulation of palliative therapy? You should look to the evidence-based present in literature. So what are the main literature sources? These are all evidence-based literature sources, but I made these three in red to be of priority for parenteral incompatibility. These are specialized in parenteral incompatibility. You might find information in the others, but these are the most common for you to find this information. Mix or not to mix. What are the evidence in the literature of compatibility or incompatibility? For example, you might find something like this table. You might find this when you search your drug by name of the active drug, generic name, and then you you will find in front of each one it is compatible in syringe with these, incompatible with syringe with this. Or you might find no evidence, no published data. There is no information for this, or there is no information for this. So this is a guidance. If you see an information here, it will tell you to mix or not to mix. For example, dexamethasone. Sodium is compatible in syringe with metoclopramide, with ondansetron, with ranitidine. So you know, if you can mix them freely. Or incompatible in syringe with midazolam, prochlorozepam, promethazine, and cyclopyrrolate, so on, so on. So this can be of helpful for you to check this quickly, and they summarize this information for you and give you sometimes comment explanation why this and what you should care about. Type. What if you don't find this solid information? You have options. We have options to take a decision, one of these. So for example, look for the obvious. Look for the obvious means acid base, cationic, anionic, pH change. These are potential. So if you see this, you say the chance is high for interaction, because I know this is a cationic drug, this is an ionic drug, possibility of interaction is very high. The pH of this is 7, the pH of this is 5, is 3, is so you can quickly, the obvious is to the possibility is high, so you avoid it, or the opposite, there is no possibility, or there is no obvious evidence because they are not, neither cationic, neither anionic is there, no pH, no acid base, and so on. If you see no obvious potential incompatibility, you can try first to mix them and observe before giving them to the patient. So you mix them yourself and monitor the signs: color change, turbidity, evolution of gas. Nothing happened, this is good. In this case, you ask the nurse to mix them right before administration. Why, guys? Why right before administration? Because we mentioned that time is a factor. The time is a factor. Increasing the time of contact increases the chance of incompatibility. So you reduce this time by being mixed immediately before injection and injected. And if you tried the combination, there is no obvious potential, and you tried it, nothing happened, you might take this decision and tell the nurse mix it right before administration. Or you might decide that we can give them separately. We can give them by bolus injection and no need for this. So these are the decisions that you may take in these cases depending on the situation you are facing. Okay. Administering of drugs through the same IV set. Yani we mentioned in the same syringe for small volumes. Other common practice is mixing them in the same IV set. We mean in the same IV set if this mixing occur between the fluid container. The IV set is from the fluid container till the hub of the vascular device. Till the hub of the vascular device getting inside before the needle here. This means this is the IV set, the set of IV. So if they meet before the hub, this means this is administering in the same IV set. Why we might need to mix drugs in the same IV set? There are a number of situations, clinical need for this. Patient with fluid restrictions. Fluid restriction, we minimize the amount of fluid in their body because of this situation. Patient with congestive heart failure. Congestive heart failure is weakness of the heart muscle, unable to pump the blood. So we treat this case by reducing the volume, the blood volume. So we give diuretics. So if we are infusing or giving this patient much fluids in his blood, we increasing the blood volume. So we try to minimize this. If he needs more medication, we can just give one them as a sideline in a small volume to avoid this issue. Renal failure patient, unable, their kidneys are unable to filter, so you also don't want to increase the volume of the blood and give more hazards for their kidneys. Severe edema, patient with accumulation of fluids, so you are worsen the case by increasing the volume. Pediatrics in general, there are limitations to give volume for pediatric because of their age, their heart, their ability to take fluids, parenteral fluids. So in this case, we might need to mix drugs in the same IV set if no problem will occur. This brings to the piggyback issue. Piggyback issue is sideline line that combines to the main IV line before the hub. So this mixing is called in the IV set. They mix it here. After connection, this part, the two drugs will be mixed together. But if there is interaction occurred before the hub, this will lead to serious problem, will enter into the body. For example, In practice, a patient, this is a case, patient receiving continuous infusion of aminophylline 1 gram in 500 ml of dextrose 5%. An order is written to administer cimetidine. They put him on cimetidine, 300 milligram per 100 ml dextrose by piggyback, IV piggyback. Okay, this is IV piggyback. So we, instead of diluting this in another 500, they said give it in piggyback 100 ml to be given with the same line. Okay. When you looked to this order, you investigated the possibility, and you found that aminophylline pH is 9 and cimetidine pH is 4 to 5. So there is possibility of incompatibility here. So you you did not recommend this order, and you recommended one of these. Give through another IV axis if there is another IV line available for the patient, or give bolus IV, small volume injection of cimetidine. Of course, will not be in 100 ml, so it will be concentrated injection of cimetidine, or consider to give the cimetidine per orally if the patient is conscious and can swallow. You can recommend this forms of in such cases. Another example for this issue too is for dopamine. Patient on continuous infusion of dopamine, 800 milligram and 500 ml of dextrose. Order written for 2 ampoules of sodium bicarb to be administered with this pH of dopamine. So they usually inject the ampoule sometimes in the tube directly. So dopamine HCl is 3 to 4.5, while bicarb is 8. So this can lead to precipitation, color change, and formation of a new compound by dopamine when dopamine is precipitate due to this. So you recommended to give bicarbonate by IV bolus IV in a different port, or stop dopamine for a while and flush the Y injection, and then inject the with normal saline, and inject the bicarb separately. But this is examples of administration in the same IV set, or admixture in the same IV set. The third is admixture in the same IV solution. The same IV solution is common also. This is by mixing, preparing the parenteral admixture that is common in IV room. Orders for patient that they need their medication to be ready for the next day is coming to the IV room 1 day before, and they start to prepare it and store it so that next day it will be given directly to be released. So this is common for TBN. TBN should be prepared ahead. This is common for chemotherapy and many other occasions that the parenteral order is prepared and mixed. So we consider this admixture in the same solution or in the same bottle. Okay. Example of serious incompatibility problems occurs is always in TBN, the calcium and phosphate problem, or the chance of precipitation of calcium phosphate in TBN admixture. Both are required, should be given. So there are recommendations to avoid this, including the use of monobasic potassium phosphate instead of dibasic potassium phosphate, because monobasic potassium phosphate as a source of phosphate will not might form calcium monobasic phosphate. Calcium monobasic phosphate is a soluble, so no precipitation might occur. We don't have problem if they form the salt together, but the problem is coming from the precipitation and the possibility of embolism and serious problem for the patient, because TBN is given to unconscious patient most of the time, or patient who unable to take his nutrition through the mouth or even stomach tube. So those patients should be given they should be take parenteral TBN, total parenteral nutrition. Okay. This one occasion. Generally, what is our recommendation for admixture in the same solution? First, consider the key factors: time, order of mixing, temperature, concentration, and pH. We'll give you examples for each factor of this and the impact of this factor on the admixture in the same IV solution. First, the time. We mentioned general rule is to minimize the time as much as possible. So the contact time should be reduced. Don't prepare your solution and leave it for long period of time. Generally, there are general rule that parenteral nutrition solution intended for use within 24 hours. So admixture will take a label of use within 24 hours. So you cannot prepare them longer than this, even though you try to minimize this within the 24 hours if possible. Okay, if possible. The longer the calcium and phosphate are present in the admixture, the more the tendency for interaction. Well, this is obvious, so you minimize this. This is very important. Another issue is order of mixing. Order of mixing is critical for TBN, for example, and there are many procedures, guidelines for a way of order of mixing that if you follow, you minimize this and you end up with no precipitation and no incompatibility. For example, this is an order of mixing procedure for calcium and phosphate. They say add calcium source to high concentrated dextrose. The idea is you try to dilute both of them first before mixing the two together. So you dilute calcium source with concentrated carbohydrate, high concentrated dextrose. It's part of the TBN2. And add phosphorus to amino acid. You dilute phosphorus salt or potassium monobasic phosphate, for example, we mentioned earlier. You dilute it with the amino acid solution, because amino acid is an essential part of your TBN. So this you diluted both. Then you start mixing, combining the two main component together. Here calcium is diluted, so the solubility is high. Potassium phosphate is diluted and more soluble. So even if some calcium monobasic phosphate is formed, it will be diluted and it will be lower than the solubility product, so it will always be soluble. Okay. Another order: add phosphorus first to parenteral nutrition, then add calcium with constant stirring. So you don't add them together. Another order, and different than the first one. So you add the phosphorus first and then mix well. Then you add gradually. You add the calcium, and upon mixing, upon stirring, till no precipitation occurs. You observe. You store it in the fridge and you observe before giving that it is no turbidity occurs. The third factor is temperature. We mentioned that temperature is critical. You always minimize the temperature to avoid the possibility of incompatibility in general, but sometimes freezing is different. So the common practice is to store them in refrigerator. For example, calcium phosphate solubility decreases at higher temperature. So at room temperature is more chance to precipitate, while at lower temperature this is different than you expect. Usually we expect that because this is sometimes is exothermic. So when you increase the temperature, the reaction will be reduced, okay, will be increased, okay. Precipitation occurred with parenteral nutrition high in calcium and phosphate when used via subclavian catheter. Yeah, this is very interesting. You know, subclavian catheter usually attached at the chest, so in the subclavian vein. So, and they found that patient taking this in the subclavian, they suffered some embolism due to precipitation of calcium phosphate insoluble. The reason for that, the tube was attached to the body of the patient, because you know the subclavian is exposed, and they attached the tube going into the subclavian is touching the body of the patient, and with time this tube gets warm by the body temperature and get closer to 37. This caused the precipitation in the tube. So due to the temperature, they investigated that it should be away from the body. This tube should be away from the body. Yani they followed the right order, and the TBN did not precipitate over the 24 hours of storage in the fridge, and then during the injection, during the administration, they found the turbidity and the problems occurred. So they understood that the temperature playing a role, so make sure to avoid. This is very interesting example, okay. The concentration, of course, you try to minimize the concentration in order to avoid the interaction. Also, calcium and phosphate concentration should be reduced, and there is recommendations, general recommendation, that not to use concentration higher than 15 millimole, 15 millimole of calcium or 15 millimole of phosphate in TBN. So the maximum you go is 15 millimole of both salts. This might be, we'll see. The pH also is another issue. pH, increase in pH results in the formation of more dibasic phosphate that can combine with calcium. So the pH plays a role in forming the calcium phosphate, insoluble calcium phosphate. So if the pH is more higher toward the alkaline pH, this can result in less soluble dibasic calcium phosphate will be formed more. So you adjust the pH to be low pH. This will help. That's why the recommendation to reduce the amount of calcium and phosphate in high pH. We mentioned in the previous slide that the recommendation to use concentration of 15 millimole maximum. They said if you are using aminosin 2% plus dextrose 20%, which is pH is 5.1, you can use more than the 15. You can increase the tolerance limit up to 20 millimole or milli equivalent. It's the same. Milli equivalent is the same here as millimole, okay, of calcium and phosphate. On the other hand, freamine 3 free amines 3 2%. This is amino acid solution, and dextrose 10%, which have pH 7. No, because we mentioned increasing the pH will increase the chance of precipitation. So the tolerance limit has been reduced to 5 milliequivalent instead of 15. Okay, so the pH plays also a role in the precipitation of calcium phosphate, and pH plays a role in admixture in general. Okay. The last thing is interaction with the material of the container. Yani we mentioned interaction in the same syringe, in the same IV set, in the same solution, and the fourth category in the same interaction with the device, with the material, with the container. Okay. There are a number of examples, interesting interactions and recommendation that tells you this is very critical. Cisplatin, an antineoplastic drug used for treatment of cancer and many types of cancer, interacts with aluminum, causing loss of potency. Where is the aluminum? The aluminum in the needles of the device, the needle of the IV set. So they found there is recommendation to use stainless steel needle for cisplatin. If you are giving cisplatin, you make sure that the needle that is used is stainless steel and not aluminum, because aluminum will absorb cisplatin and cause occlusion and cause problems. Nitroglycerin is also known to interact or to be absorbed on the walls of PVC tubes. Where is the PVC tubing? If you are using a PVC infusion set, or infusion set made from PVC, this should not be used for nitroglycerin infusion. Why? This will cause absorption of nitroglycerin on the walls, resulting in reducing the concentration of nitroglycerin entering the body. So you found the potency of the treatment will be much reduced. Nitroglycerin is giving in acute angina, so this is very critical. Recommendation to use non-PVC tubing. Also, insulin and all protein drugs are known to be absorbed on the walls of all containers, all types of containers. So this can reduce the potency of insulin. Same thing, insulin by infusion is giving for hyperglycemic shock. Hyperglycemic shock that needs quick reduction of the glucose. So it is serious. The protein will be absorbed on the walls. This means no drug is going to the patient. So you see it's no treatment. So that's why this issue, because the absorption will reach 80% of the drug. 80% will be taken on the walls by absorption. So there are a number of strategies in case of insulin to reduce this chance, because this happens with all materials. It's not a material dependent. It is the protein nature, the protein able to be absorbed quickly. Okay, what will happen in this? What are the solution and option? Is you add human serum albumin to infusion. Human serum albumin. What is the role of human serum? Human serum albumin is a normal component of our plasma, and that's why it's safe. So if you mix the insulin with human serum, with large concentration of human serum albumin, what will happen? The human serum albumin is a protein. It will be preferentially saturate the walls of the container. So the insulin will not be absorbed, or the extent of absorption will be reduced, because the majority is ratio of insulin to human serum albumin is very low. So that's why the wall will be saturated with human serum albumin. It's a protein, will be absorbed and minimize this. This is one option. Another option is to take uh, a small amount of patient blood before giving the insulin and mix it with insulin. So human blood contains albumin from of the patient himself, and you re-inject again, re-infuse the insulin blood mixture, patient blood mixture into the patient again. So this will avoid, because the same principle of serum human albumin infusion will be with the blood mixture. All or they another issue is you first infuse the apparatus with insulin for certain period of time to saturate it with insulin, and then start connect the hub to the patient directly. So you saturate the tubing with the insulin to avoid the loss due to interaction with the container or absorption with the container. By this we finished, guys, all the issues related, and you can find them a little bit correlated, a little bit differentiated. So I hope you review again the examples, you categorize the different issues appearing, you concentrate on the examples. Examples is very important to understand the nature of this IV admixture. Also, all the issues related to safety will be highly emphasized, so concentrate on this, warning, threatening, and so on. I hope you will digest it easily, and if you have any question, you can reach me also always through email and WhatsApp if possible, and also we will schedule a session for question and answer shortly and inform you with this. Thank you, and see you in another lecture. Good luck, guys.